Hello everyone, this is Chadi Alraies from CVI 2022 in Denver, Colorado. I'm really privileged to have Dr. Mahesh Anantha. He is the Director of Cardiovascular Services at the White River Medical Center, and he's also Assistant Professor of Medicine at the University of Arkansas. Mahesh, always nice to see you.
Oh, nice to see you, Chadi. Nice.
Yeah. And you have been always contributing to CVI since fellowship and now became a faculty, especially in the peripheral sphere. And you have a nice talk about approach and management of long segment calcified region in the peripheral space. Can you tell us more about it?
Definitely. It's a privilege to be here at CVI, and I've been attending this conference since I was a fellow, first or second year fellow, and it's nice that this is the first time I'm being a faculty at this conference, and it feels really good. I have a few presentations in this conference. It's exciting, and I just wanted to talk about this topic of interest, which we all deal with every day. It's long segment SFA occlusions. I just want to put together what strategies that I feel is helpful in patients with long segment disease, be either calcified or non-calcified disease. But I wanted to start with any CTO of long segment SFA. My first approach is, before I plan for any intervention, I want to make sure the indication for this. I mean, there's always people who are just Rutherford class 2 or not more than 3, and they don't have major symptoms, and you don't have to open up everything and everybody. So I just plan for this by getting an ABI before, and if it's significantly abnormal, below 0.8 or something, then I look into a CTA. This CTA for long segment occlusion does give me a lot of idea about my approach.
Exactly.
So I prefer to get a CTA if possible, if not an ultrasound if the patient has CKD. And once after I get the strategy, by getting a CTA, it'll tell us the level of occlusion, and if there is common femoral artery involvement, or if there is just SFA involvement, long segment occlusion, or if it's going all the way down to the popliteal, because these are things that will alter our decision based on what instrument or equipment we can use for this revascularization. And also the degree of calcification tells me a whole lot. If it's calcified vessel, approach will be different. And the other major thing I look for is my runoff below the knee, and this is golden to know before you approach any case, mainly because of pedal axis, if you're able to use that. The reason being, if you're coming from pedal axis, your chance of staying intraluminal is much higher than coming from up and over. So once after I plan for a CTA for patients with CKD, then I usually go up and over strategy, as long as they have a small segment that's available in SFA that I can get through. My initial strategy is simple. If it's a short segment, then use a glide wire, which is as straightforward as that, and a microcatheter. And I prefer to use angle glide or an avicross catheter, and then I try to get through that. If it's a short subintimal, it releases knuckle and then it goes back into true lumen. Then I try to just keep it as simple as possible. And then once after I cross through that occlusion, then use a chocolate balloon and then maybe a drug-coated balloon. I try to avoid stenting as much as possible. If it turns out to be a long segment occlusion and I have to dissect all the way down there, it's not worth it, and I will end up stenting, which is something that I don't want to do. I either go for a strategy of re-entry devices, or I use Ocelot, which is one of the devices that I've been frequently using to stray intraluminal.
Which is ultrasound guided.
Exactly. So it's image guided CTO device. The advantages of the device, I can see the vessel size, and I can see I'm remaining true lumen, and I can always reconnect down there into the true lumen. So if my initial strategy of wire and a microcatheter does not work, then I try to go from up and above, trying to go with Ocelot microcatheter and try to revascularize. If it's a long segment, I try to stray into lumen and try to re-enter. If it turns out to be a difficult Ocelot, sometimes we cannot get enough support. The catheter is not as stiff. You may not be able to push through that. Some people have a very angulated, steep bifurcation. In that case, you won't be able to advance that Ocelot too, so you run into some difficulty. So there, if it's a short segment, I still try to push a wire through, which can be knuckle wire, as even as a Mongo wire, or anything that take a knuckle like a Fielder XT wire. If it's a big vessel, I try to go with the angle glide wire, and I go with the short segment, and if I see a re-entry plane, I have both Outback and Pioneer re-entry device. Pioneer is better because I have imaging to say that we are entering the true lumen, but Outback with that shape, you can still predict your entry if it's a big vessel, and I try to re-enter the lumen and try to get back into the true lumen, and mostly try to perform balloon dilatations. If it is difficult to access, if you're dissecting a whole lot, if you're not able to re-enter, simple strategy is trying to go pedal access, and I try to mostly access the PT. The problem with accessing AT for me is that angulation, and sometimes if you're trying to use an Ocelot or drilling device to come from below, your angulation can prevent you and kind of buckle the catheter, and I've lost a lot of the Ocelot catheters, and pushability, plus also the catheter gets damaged with that angle and that AT. So I prefer to get PT, and if possible, if it's not a deep calf, like if it's not a pretty big leg, then I try to go for even PR sometimes if it's an okay vessel, and as a straight course actually helps. And then once after you come from that, I either try to enter with ocelot back into the true segment. If we cannot re-enter, then I try to go with reverse cart, which is predominant success for me is using reverse cart from my limited experience that I have in the last year. And every time I have a balloon in the short segment above and dilate it, and then come with the poking wire below that and try to get in that same plane as the balloon when you deflate the balloon, pretty similar to the coronary reverse cart that we use, and I've had pretty good success with that. For me, some people say a 014 wire, but for my strategy for leg, I prefer a 035 wire, even if it's a pedal axis. As long as it's a big vessel, I do prefer an 035 wire. And once after I get it up there, I try to always externalize. It limits a lot of step. Even though you're okay, your pedal size is big, I most of the cases try to externalize with rendezvous technique or just come out with a glide wire, and then I try to exchange the microcatheter and use that left groin
Tell us about the rubber exchange. How do you externalize the wires?
A very good question. So from my experience, I try to, if it's a 035 wire, you have an advantage. You can actually try to spin through that sheath, and you can get it out of the sheath, and the destination you have to remove that sheath cover, and then you can pull it back, and then you put a hemostat, and then you lock the destination back again, and you can flush the sheath and lock it back again. Once after you come out of this, then you have wire control here. So I take my microcatheter and I put it backwards this way, and then once after the microcatheter comes through and through from your pedal and your left groin, then you take the wire out and put it in the opposite direction from the microcatheter.
Yeah.
That's the simplest way of doing it. But rendezvous technique, I try to advance the microcatheter into the SFA and try to wire through with 014 wire. I can get through if you're on the same
Because you
plane.
have a landmark.
Exactly, yeah. It's pretty similar to that coronary technique where we try to keep the microcatheter in that retrograde, antegrade guide catheter, pretty similar to that, but it kind of can get tricky for me. I prefer to just go into the sheath rather than trying to externalize the wire through a 014 into a small microcatheter. The only thing we have to be very careful to avoid doing is try not to re-enter in the CFA. Then you probably are done. You have to stand across the CFA. You have a dissection. That's really bad. As long as you stay below the SFA, below the CFA, and you're able to externalize the wire with the true lumen in the SFA and CFA, then it's great. But if you're dissecting all the way and trying to re-enter into the CFA, that's a bad idea. I would probably stop at that point, even let the vessel heal and bring them back and try to re-attempt it. But once after you externalize, then it's pretty straightforward from left up and over. Yeah. And sometimes we deal with all this calcified vessels, like I was presenting a case today, pretty calcified segment. Even getting a destination sheath up and over is extremely challenging. We had to use balloon-assisted tracking. In that case, your fine techniques won't be able to work out. Like, for example, getting 014 wire through a calcified segment, I don't think you'll achieve success anytime. So I just go big in those catheters, just use the angle glide wire, try to fight it out back and forth and try to get into that. Try to avoid atherectomy if it is in subintimal plane for a long time. But if it's more calcified segment, I finish up usually with atherectomy. And now I've started using more of the shockwave balloons for SFA. We have good sizes for that. So I've been using that. Yeah. But sometimes additional modifications needed on top of your shockwave. Right, so I try to use atherectomy on top of that. Yeah. And we go to devices directional atherectomy. And I do use CSI in this peripheral space as well.
Nice. Well, that's a very comprehensive overview of how to approach. I went through over a full manuscript of a review paper on how to approach these lesions. Thank you, Mahesh, for your time and for your expertise, and for sure, limb salvage and also critical limb ischemia is your alley now. Please watch these videos and others on CVI YouTube channel. This is Chadi Alraies from CVI in Colorado. Mahesh, thanks so much.
All right, thank you so much again. Thank you for the opportunity.